So first of all, thank you, Gemma, for the very kind introduction, and indeed the Tracheostomy CEN for enabling me to come and speak to you about compassionate care in paediatric tracheostomy. I think the first thing I'd really like to say is that I don't want this to be about if you are not carrying out compassionate care, you are therefore lacking compassion. And I hope that comes across in the slides that I will be sharing. So just some disclaimers, really. I really want to emphasize that this presentation is not a technical presentation. Actually, it's quite out of my comfort zone as well, as somebody who's very comfortable with working in the world of anatomy and physiology. It makes sense to me, so I'm out of my comfort zone as well. And I think it's really important to understand that throughout the discussions I have today, that I cannot emphasize enough that it's really important that clinicians, particularly with less experience in this field, do refer back to the specialist centres and the paediatric airway centres, particularly to try and understand that anatomy and physiology. So the reason for tracheostomy, the reason for ventilation. It goes without saying that it can be incredibly complex, including expectations, surgical intervention. I hope I'm not speaking out of turn, having linked with many of the airway centres across the UK and had the privilege of working in a few of them. You know, the clinicians are very approachable and really keen for this two-way dialogue. So please reach out, please discuss, please think about, particularly in this world now of Zoom and Teams, think about joint working. Can that work through video? Certainly something we're looking at more and more. And finally, to say these really are my clinical experiences and represent my learning, but my continued learning. I don't profess to be the expert by any stretch. I hope I bring some expertise, but more importantly, I hope you out there watching will also bring your expertise and your experience. So we always do this thing of learning aims and objectives. To be honest with you, I'm hoping you have your own aim and objective depending on why you've turned up to this webinar. I'm hoping you're thinking about, okay, what's this mean for me? But for me, my aims are to share. I'm really passionate about sharing the skills that we have and through our experience, what we learn. So I will share some of my clinical experiences of working with children and young people with technology, as I'll refer to, so trache plus or minus ventilation, how these experiences have shaped my clinical practice, massively important what the families have taught me and the children themselves, and what compassionate care looks like and what it might look like in clinical practice. So a little bit about my background. As Gemma says, I am all over the place, but I love it. I feel very lucky to do a job I am absolutely passionate about and get to learn every single day. And with learning comes this thing of failure. So I have learned the hard way, and I think it's the best way to learn because particularly with children and families, they help you understand this roller coaster journey. I feel very lucky to have worked across the journey for children and young people with tracheostomies and ventilation, so in acute community and rehab. And a new world for me in the last few years is the medical legal world, which has also taught me about what it means for families who perhaps have difficult journeys through healthcare, navigating healthcare, and really hearing from them that actually it's not about litigation or financial gain, it's about their voice being heard. And importantly, that the same issues don't happen for another family. I think, as Gemma beautifully pointed out, transition's a really important thing. And just here I'll mention that children and young people with trachea and ventilation needs will transition obviously into adult services where those are long-term needs, and where we perhaps would say that the children are surrounded by paediatricians and paediatric focused teams. It's more challenging in adults because whilst you might have a geriatrician, we don't have an adulttrician, and so sometimes these families can feel a bit lost in those early years. So really supporting them through that journey has helped me understand what compassion might look like as part of that journey. I have the absolute privilege of offering training, which I love, mentoring and supervision, and really learn. It's a two-way process for me. It's definitely not a one-way system for me, and I learn as much as I feel like I can share as well. And finally, from research, I think more and more we're being encouraged to think about public and patient or patient involvement in research. And this has kind of led me to reflect on what that looks like clinically. And I suppose one of my challenges, and I'd be interested in the audience, and please do use the chat for this, is that we're assumed communication specialists, but rarely do we get any training in having difficult conversations. And for me, this is really where this has all come from, is that if I'm going to give you a clinical example. So many years ago, I was stood in an intensive care unit with a young girl who had post brain tumor debulk, ended up with quite a devastating consequences. Unfortunately, she had significant complications, required tracheostomy and ventilation, and had very little movement from neck down. And during a consultation with parents, I'd met parents previously, a nurse came over and went, "Oh, don't worry, you'll be eating and drinking in no time." And I remember being really shocked, going, "Oh my God, oh my God, oh my God, this person doesn't understand the underlying condition." And then mum came over to me and I said, "Well, you know, it's a journey. We need to look together and we're going to be thinking about this." And, you know, in my head, I'm going, I'm the expert in this. I know what's going on with this trachea. I know what's going on with the anatomy and physiology. So I've got this. And I wasn't prepared for the nose to nose that happened with that mum as she screamed at me that I had no idea who her daughter was, and that me telling them that they weren't going to get her fed was ignoring who she was, and really not thinking about what they knew was going to happen. She was going to orally feed. And that was really tough. And I have to say, I scooted off to the sluice. It's the best place on a PICU to go and have a little blubber and then come back and try to be professional. And it was a reminder that I'd missed the point, really. If anybody looks at the research around, I suppose most trachea, I can only speak for the paediatric population, the word that comes out is heterogeneous. These are a heterogeneous population. And what I'd done is applied my understanding of anatomy and physiology and just rolled with it. And what we needed to do was come together as a child and family to talk about it. Scroll forward. What this led to is this family were keen for this child to eat. And it was really tricky, and with medical approval, we decided we would try something, even though clinically we didn't think she was ready. And one of the hardest points in my career, she spouted chocolate mousse from her trachea. And I have to say, it was awful. I was not proud of that moment. I wasn't standing there going, "I told you so." I was standing there and seeing the mum see her daughter not succeed. But what it did was it changed our relationship. And to this day, we still have a really good relationship and an honest relationship. And for me, that started to change how I looked at how I work with families. So I'm really keen to understand, what's your experience? Who gives you that training in having those difficult conversations and those challenging your clinical thinking and your sets? And, you know, I'm absolutely talking about my experience. Who is it that gives you that? Where's that come from for you? Because for me, some of the experiences I've had, and I feel very lucky, is in intensive care, where I've seen, for example, a medic either break bad news or talk about difficult news. But it's not something we're trained into as clinicians. I think a lot of it is presumed. And unless you see it, it's really hard to just step into this role. So a little task for you, which is really weird because I'm literally just talking to myself right now, and I'm assuming there are people out there. I'd like you to think about tracheostomy, and I'd like you to think about, depending on what your experience is, but I just want you to hold up how many fingers as a representation of how much you know about tracheostomy. And for example, you know, if I think about my clinical experience, I've still got loads to learn. So I'm going to hold up 8 fingers or 9 fingers. Can't count today. 8 fingers. That's how much I think I know. I've still got a lot to learn. That's how I feel. I feel confident, but I've got some more to learn. And then if I said to all of you, hold up how many fingers you know about speech and language therapy. Now, assuming the audience, I'm kind of hoping you all do this. And we've still got stuff to learn, but this is our bread and butter. If we were to do the same thing to our families and say, how much do you know about your child's tracheostomy? They'll do this. How much do you know about speech and language therapy? What I'm trying to show is that it's about teamwork. And what I feel is that we come with knowledge and skills about tracheostomy and speech and language therapy to a family who know this child better than we will ever know them. We step into these lives in acute, we're with them for a long time as they transition from initiation of tracheostomy with ventilation out. But then as they transition out to community, you may not get that contact. You may not get that interaction as much. And so families are day in, day out living with this child and learning about their tracheostomy and their child. And we step into that. It's a privilege to step into that for a brief moment. And in the grand scheme of things, it really is a brief moment, and try and offer support and care that's based on our generic learning and our experience, but is about a unique individual. So just going back to the speech and language therapy thing, I absolutely must emphasize, I'm not dismissing the reason for a tracheostomy, and in children particularly, it can be a really complex airway issue that maybe, for example, a child would never be able to achieve voice in laryngeal atresia or in complete agenesis of the larynx. You know, it may be for lots of different reasons. But as a speech and language therapist, particularly working in peds, what we are trained to understand and trained to do is think about language development. And I think we have a responsibility to stand with these families and say, well, hang on, we're not talking about speech outcome yet. We're talking about the whole pyramid. There's stuff we can do that is not about voice output, but it is about building communication. It's about supporting and scaffolding. And we can join in a conversation of that, of understanding what is pertinent to that family. It is about taking what the child is demonstrating, and I appreciate this is really hard and this is challenging, but building on what they're already doing in a way that supports and develops communication. So I've tried to think about what it is about tracheostomy and ventilation that can sometimes be quite paralysing for us. And I say this as somebody who speaks with privilege, that I've worked in it for a long time in different fields, and I'm not particularly phased by a tracheostomy. I've been involved in emergency interventions and been lucky to be in theatre, so I'm less nervous. But I do really recognise that, particularly working with community colleagues or with people with less experience, it can be really scary. It can be the only thing we end up focusing on. And all we see is this tracheostomy in the neck, this white bit of plastic in the neck, and it's almost paralysing. It makes noises. It's got gunk coming out of it. The HME keeps popping off. I don't know why they've got it exactly. Is it long term? Is it short term? There's all these weird noises. What happens if it falls out when I'm doing a session? What do we do then? What happens in an emergency? What if they ask me something I don't know? And I think these are really realistic questions that more or less go through our heads as we go in. I think one of the things I always say to people is ask the question. I think one of the things we're afraid to do is ask the questions that would actually free up some of our anxiety. So, okay, in an emergency, what do you expect me to do? I can see you've got your blue trachea box, so the blue box they carry around with the tube in the downside. What's in that? It's okay to ask these families. They carry a huge amount of knowledge about their children. And if we sometimes don't ask these questions, we're creating barriers in how we can then connect with them. I wanted to touch on this campaign, which is, it was a campaign that was a few years ago now, but it's very much still running, and it's the hashtag Not a Nurse But, and it was run by Wellchild, who's an organisation that supports children with complex needs and often with trachea and ventilation needs. And obviously you can read that there, but it was a really important campaign to show how much knowledge and experience families and carers have of their children and the amount of work they have to do to support their child. And I think, again, as clinicians, we need to be mindful of this when we step into their world. We need to be mindful that they may have been up all night because the carer didn't turn up to look after their child. We need to be mindful of the fact that they have strangers live in their homes to look after their children for if they've got a care package that requires overnight care. And I think we need to remember that when we're trying to engage in our bit of the puzzle that these children are going through. We need to understand that there's so much more that might impact on that connection and that understanding. And we have a lot to learn from families who are doing, 9 times out of 10 doing incredible things with best interest. So I just wanted to share this lovely quote from Schiarati, who looks, she's got, it's really good to go and Google, My Abilities First app, which was looking at education of medics primarily. And she was saying that we have often come from a needs approach, so looking at people's disabilities rather than their abilities. And again, I think this is, as a clinician working, again, more broadly as a speech and language therapist, but certainly in technology, is we get stuck on the technology and therefore we're looking at the disability or the impairment and we're missing the bigger picture. And I think this just really summarises the importance of kind of standing with families to understand how they're taking the lead in the care process and how we can learn from them. So we'll come back to this definition, but dictionary definition makes me feel really uncomfortable. I mean, I don't know if it's about suffering or bad luck. I'm not sure some of the families would use that terminology. But I think the 6 C's campaign from the NHS, which was back in 2015-16, really sums it up. And the words, I mean, again, difficult to interact with you, but what words stand out for you on this? What is it that you can see that think, oh, that's something that resonates? So for me, it's empathy. It's acknowledging someone's pain without having to fix it. It's acknowledging that I can imagine this is really difficult for you, rather than I can't imagine what that's like, which just shuts that conversation down. There's a lovely phrase by Dr. Edith Eigel, who's a psychologist, who says there's no hierarchy in trauma. And I think it's really important when we come together with these families, it's not looking at these families going, they've had it worse than me, or I can't bring anything because my experiences don't match theirs. It is about being truly empathetic, that you can imagine how hard this must be day in, day out, having to change your child's, not necessarily day in, day out, weekly, monthly, change your child's tracheostomy, suction them all the time, be their carer, their nurse, rather than their parent. The other words for me, respect and dignity, and this lovely term, intelligent kindness. Kindness is not about making it all soft and lovely. Kindness is actually about speaking truth and about being honest. So I'd like to present a couple of cases. I have to say, disclosure is that the families have given complete consent for the words and pictures to be used. I am indebted to them because even receiving this information, I am just humbled by their words. So I'm going to introduce Ella, which some of you may know. Ella's mum gave a beautiful presentation at the UK Swallowing Research Group last year, and is one half of the brilliant Singing Hands. Please do go and have a look. That's does some Makaton singing, and they do like a carpool karaoke. It's brilliant. Suzanne's daughter Ella was born with charge, and she describes charge association. I know there's debate about that term. And she had a complex airway that required a tracheostomy at 9 months old. And unfortunately, there was no potential for voice. I was delighted to hear that a speech and language therapist got in really early there, and Makaton was recommended. And by 10 months old, Ella had already learned her first sign and had 80 signs by 18 months. She was gastrostomy fed and nil by mouth. And I think just to touch here, this is not the topic of this presentation, but one of the powerful things here is that Ella has transitioned to adults and has recently had video fluoroscopy that shows that she is actually able to now swallow. And Suzanne updated to say she's doing really well and trying lots of different flavors, very nervous because she's had about 20 years of not eating. So it's quite exciting for them, but it challenges us to think, do things change? How do things change? I don't really want to talk through these. I think it's really important you read them. I found them so powerful for me as a clinician who feels like I'm navigating the compassion journey. A window past her tracheostomy. Sometimes we get stuck on the diagnosis on a piece of paper that we lose sense of what we're there for. Sometimes we have already made a clinical decision about what we are going to see, that we have already biased the outcome. I just really want you to think about that. Sometimes we need to park our clinical bias and really hear the family and say to the family, show me. Walking in there and me telling them I want them to do it this way is not seeing how that family cope in real circumstances and when I'm out the room. Show me. It's such a powerful thing than let me show you, or in my head, I've already made a clinical decision. That's not negating that we need to think about all that information and all that history and understanding, linking in with our tertiary centres, getting that information. Oh, it's a gorgeous picture of Ella, quite a long time ago, I'd say. Ella's now, I think, 2021. But look, again, this really, I think this shouts about the power of you as a speech and language therapist. This is more than just I shouldn't say just, because I'm proud to be a speech therapist that works in trachea, but more than the complexities of putting on a one-way valve or finding out whether that valve is going to work. You all have the clinical skills to support this family on the journey of communication. That sentence there, all that receptive language had been going in, just waiting there for a chance to come out. So she had her voice post-decannulation. Children are sponges, but how we input it, how they get it is really based on that parent or that carer interaction, that adult interaction. If we miss an opportunity to support that because we've stopped at the trachea, then we're missing an opportunity to support development. Again, this was from Suzanne. So this really resonates as well. I think sometimes, and I absolutely, this is my journey, I definitely felt I was there to fix things. I'm there to get this right. And I'm going to get it right. And I know what this is, and it's broken, so I'm going to fix it. That's definitely been me as a clinician. But actually, it's not my job to fix things. It is my job to support, and it is my job to ask other people and to check in with other people. This is such a powerful sentence. See past the medical issues to the little girl who wanted to tell me something interesting and who wanted to initiate communication. I think this goes for bigger diagnoses, and I think this probably goes beyond our profession, where the diagnosis goes before the child, and I'm really keen that doesn't happen. I think we recognise the child first. These are a heterogeneous group. Every child brings their own dynamic quality and spark and hope and dream, and the families, that's what most families want, is for their children to be healthy and well and happy. This beautiful quote by Rachel Remen really highlights it, and I say this as somebody who, I can see the chuckling already, I love to chat, I am a chatterbox, but I'm learning to listen, and part of my compassionate journey is checking in on that and being more able to listen, being more able to leave the gap so I don't have to fill it. I don't have to fill the gap. I don't have to have the answer. That's true compassionate care, is giving that joint attention. I'd like to introduce you to Lola now, who is an incredible young lady. She's 2.5, and she had a tracheostomy around about 6 weeks old, and has complex issues in terms of really struggling to get off a ventilator, but has transitioned off a ventilator, has had some airway reconstruction surgery, has a one-way valve, doing well, has a gastrostomy, but progressing with oral feeding. And her parents were very open to discussing. They're very keen to share. They want to help people understand Lola, the child behind the tracheostomy. And I think this is a really eloquent description, that this trachea kids, and we probably hear this, I think we've all heard it at some point. I'd be interested in the adult colleagues, whether they hear it as well, the adult trachees, or the tracheostomy adults, or the tracheostomy patients, I don't know, but certainly in paediatrics I feel like I hear it a lot. And the challenge with that is you stick with the tracheostomy and then we don't challenge ourselves to have higher expectations. And that's not to say you're not having expectations, but for me, it didn't challenge that. I kind of got stuck on, well, this is what I'm expecting. But actually Lola brought something else to the table. Lola's exciting. She's hilarious. She always carries a black cat, which is not in this picture, sadly. But, she's an inquisitive young lady. She wants to learn. She, those books have been off that shelves more times than I can mention. She brings stuff to we're doing Zoom at the moment, but she brings stuff to Zoom. She's really engaged. That's Lola. She happens to have a tracheostomy as well. Her parents want people to see Lola before the tracheostomy. And in this picture, what I hope you can see is you can't really see the trachea. You can see Lola. And it would be great if people could judge her on that than the noise she makes when she needs suctioning. They do feel they've missed opportunities as a family because the tracheostomy has prevented perhaps exploring some opportunities further. And I think they worry that the medical aspects overtake any interaction, and people forget to ask, but how's she doing developmentally, rather than how's she doing medically? And I think this is quite a powerful one. I think we all understand this. As a speech and language therapist who used to walk onto a ward and get, oh, here they are, the people that make them nil by mouth. I think that was definitely my first 5, 6 years, 10 years of my career was that presumption. And I think anybody that attended the Paediatric Dysphagia CEN recently knows that we are challenging our thinking, because we don't know it all. And if we don't know it all, we can't come here with hard and fast rules such as this. They're not all tube fed. Certainly not my clinical experience, and whilst there's some ranging evidence out there, we understand that's probably more about the diagnosis. Lola's doing incredibly well. I'm very proud of her with her smoothies and her drinking through a straw. She's done phenomenally. And this was quite powerful, and I really appreciate that I am one of her treating clinicians. I'm not the only one. I love this, that they feel that people get to see Lola when they connect with her. Lola, for me, it's great because I can just be a big kid and put on silly faces and masks and stuff, and she loves it. So it's really important we see what hopes and dreams there are for Lola, standing with that family and understanding what they want and what they hope for. It doesn't negate that it will happen. It doesn't mean it will happen, but we do need to hear them. And I just asked, I suppose, what the advice is for therapists. And I think this is great. See Lola for Lola. And I did not prompt for this. I literally gave quite a generic question. And one of the phrases they've often said to me actually is, we just don't want to be put in the trachea box, which is ironic because the trachea box is blue and it is, you know, we refer to it. But they understand the limitations. They understand it's a challenge, but they want people to work with it rather than against it. So I think this is where I came from. I really felt my role was to assess, intervene, and to fix. That's what I'm there for. I've got this knowledge and I've worked really hard for this experience, and, you know, I trained and I'm doing great, but actually it just wasn't sitting right. And I had, you know, the incident I mentioned at the beginning, it was more than one that I've had like that. So I'm challenging myself to be compassionate and think, what happens if we ask and observe? Show me what you do. What happens if we said, what happens when you do that? What does it look like for you as a family? How difficult is this for you as a family? And what happens if we park our clinical bias? Absolutely hold on to that knowledge, hold on to that information, but we're not using it to perhaps put a lens on what we then look at. So think about, you know, for yourself, what does compassion look like for you? And I don't mean clinically, but think of a situation where you received compassion. Think of a situation where you offered compassion. What words come to mind? And I have to say, very personal, but I think it's important to share. When my grandmama was sadly dying, she was in a hospital in Portsmouth, and I'm so grateful to the hospital. And I obviously don't live anywhere near Portsmouth. Went down in one set of clothes, and really kindly, they got a bed next to her bed. It's not what they did in the hospital, but I had nowhere to stay. I had to stay with her. That to me was compassion, because it's what I needed, and I needed to be heard. And they sat there with me and talked about my grandmama and what she was like. And we managed to get the TV working so she could watch EastEnders. That to me is compassion. It's really stepping outside of what we do well as our roles. It's not a criticism of our role. And I think we do great jobs, but it's that little bit more that connected with me on a personal level. And similarly, offering compassion, there's something out of it that makes a connection, that makes our conversations able to be more honest, I think. I think we're all able to say, I hear what you're saying, but what I'm worried about is X. And you have a conversation, not a, I say this and this is what it is. So what themes come to mind? What is that word? Think about the quote that we used. Is it that empathy, that respect, that dignity that we all crave? Is it a willingness to help other people, to promote their well-being in order that they find their solution? Is it that we have this intelligent kindness? And as Sims et al. And Sinclair et al., they both talk about this relational, individualized patient care, which is perfect because these are a heterogeneous group. We make it individualized, it's the appropriate care rather than this transaction of care. Now, do not get me wrong, I'm not all blinkered up and rose tinted glasses. I appreciate there really are barriers to this, and we'll discuss those in a sec, but I just thought it's really about perspective. What we often do, and I think particularly as AHPs, we're well conditioned into understanding the importance and value of the child and family being central to what we do. And I was reflecting on this in my own practice and trying to think about what this actually looks like. And what we often do is bestow upon families the expert model. You're the expert in your child. But when we come to having discussions, we remove that expertise and we often dictate or transaction, we offer that transaction in best interest. It's not a criticism, and that's certainly how I felt. So I wonder whether we actually have to propose a slightly different model where we bring down the family off the pedestal or from the center and bring them into the circle and having that side-by-side conversation. Let's do this together. We'll share together in this circle. And I know it's a thing of perspective, but I think it's really important. And kind of thinking of that, I'm in mind to kind of think about the Brené Brown quote, which I have to say, if anyone's had the opportunity to read any of Brené Brown's work on leadership, is so powerful. But this resonates. Honor people's perspective as truth, even if they're different from yours. it's okay for us to have a different truth, and it's okay for us to have a different experience, because we've all had a different journey to where we are now, and we all respond to things differently. But I think sometimes we forget that for our families who are living a very different truth day in, day out, particularly when they are managing technology. So as I say, I'm not ignoring the barriers. I fully appreciate busy clinical times, but I have to say, if nothing, and I particularly look at colleagues like Gemma and Sue, who are working in these acute, busy clinical areas with COVID patients, and I think, wow, we have learned so much from what compassion looks like. Families, you know, having phone calls from a nurse who has sat by a bedside for hours on end, who has enabled that call, has shared communication. You know, we've overcome some of the biggest barriers we've ever had. But I do recognise they're there. But that's my learning, and that's my opportunity to develop. Babi et al. Looked at what this looks like for nursing, and there's a lot of literature around compassionate care in nursing. Stems a lot out of palliative care and our head and neck cancer populations. So for me, my challenges were particularly coming through the profession, my experience. Like, I don't know enough about this. This is a tube in the neck that they've got a funny, there's a silver one. What's the silver one? You know, I don't know enough about this, but I do know enough about SLT. I am an SLT, and that's what I can bring. I can gather information. I can look at the history. I can look at the presentation. I can just watch. I don't have to fix it. I can discuss it. I can share it with other people. I'm unable to answer questions. Being authentic about that actually helps families. Being able to say, I'm not sure about that, I think builds trust. Take the opportunity to listen. As I say, it's something that's still developing for me, is leaving that space. I might get it wrong. I have to say, what you don't see over my left shoulder is my imposter syndrome that sits there every day. And I know I've discussed this with some other people. I might get it wrong, but I might get it right. And if I get it wrong, that's my learning opportunity. And if I get it wrong, I need to check, did I step my boundaries? Did I overstep? Did I perhaps not check in correctly? And isolation, this is the barrier or challenge I think will resonate with a lot of clinicians. Please do not sit there thinking you're isolated without support. Seek people. People will direct you to other people. I have learned so much from the people I've had the joy of interacting with, whether that's on Twitter, whether that's or face-to-face at meetings, whether that's through webinars. Please reach out. And ultimately, remember self-compassion. Like, you count as well. So checking in with yourself is just as important. And my big one, just be curious, keep learning. None of us know it all. And in fact, as each day goes on, I realize how much I don't know. Again, a Brené Brown quote. Sorry, it's not the Brené Brown show, but she is amazing. Let go of saying the wrong thing. The need to fix and offer the perfect response. And I think that's definitely where I've come through this journey. I think this is added to my authenticity and connection with families. I think I see the whole child now, and that's exciting because that opens up for me a world of different potential. It moves me away from the ICF focus on impairment and makes me think about well-being and participation and vitally personality. I can acknowledge the hopes and dreams of families. It's okay to call it out. I can see that you really wanted her to learn to sing and we're not there. Acknowledge my limitations and biases. I am biased. I definitely have an opinion based on my clinical experiences, and I'm learning to stand beside families and say, show me, before I make that decision. Families have a wealth of experience and perspectives, and their homes are like mini hospitals and storage units. They have so much experience on a day-to-day basis that we really do need to hear and honour their truths. Be the learner, not just the knower. And that's something I will continue forever. I always want to learn. I'm excited about learning. I'm excited about changing my perspective. So my question to you is, what would this look like in your clinical practice? Is there anything there that you could take away and apply immediately in your clinical practice? I do hope so. And as I say, it's not a suggestion that you're not acting compassionately or authentically, but hopefully gives you some opportunity to reflect. I really want to thank Sophie, Dave and Lola, who's Lola's mummy and daddy, who have been so generous in sharing and keen to share more. Suzanne and Ella, who kindly subsequently have given me permission to share, obviously to the CEN as well, and to all of you for coming and being open to what is a really different presentation, and one that's definitely challenged me. So I'd be really interested in questions, your reflections, thoughts, and keeping this conversation going. If any of you know me, I'm a Twitter fiend, so come and find me there. Thank you so much. I really appreciate the opportunity.
Amazing, Lou. Thank you so much for your passion, your openness, your experiences. I love the term intelligent kindness as a definition of compassion. I think that's so true, isn't it? That it's more than kindness, but it's a wonderful definition, and I think it all resonates. Again, I'm an acute adult speech therapist, but the whole of that presentation really resonated with us, because I think throughout healthcare we focus so much on the diagnosis of patients, or trying to uncover what it is that's causing the impairments, and actually not listening to patients about what's important to them and what they want to do and what they think about, and actually really getting to know your person, your individual, is so important and breaks down so many barriers. So thank you so much for that. That was wonderful. Now it's the opportunity to have more discussion, more questions with Louise and the rest of the panel about this topic. They don't have to be specific questions, they could just be thoughts. There's lots of you sharing thoughts in the chat about what compassion looks like to you, and kind of your experiences of that. So I don't know whether there's any specific questions that come up. I think one of them that's come up on a different feed for us was, and I think you've touched on it a little bit throughout your presentation, Louise, was just about how you would kind of recommend us looking to improve or facilitate those skills around difficult conversations. I think you've framed some of them really nicely about kind of not being the teller or the knower, and actually trying to learn from the people that we're seeing. So just to expand a little bit more on that.
It's really, yeah, thank you. It is a really tricky one, because I feel like I've tried to reach out and find out where is this training. I would go and have a look at the My Abilities app, which is aimed at medics, but I still think it's a really lovely way. She calls it disruptive education, which I love, because that's the minx in me that wants to be like that. But I think things like, I have put this in as one of the resources, but Amy Stevens, who does Magpie Chatter, she did a webinar on wholeheartedness, and she's kindly shared the link with the password for us. So looking for things like that. For me, it has been about having conversations with people. I feel very privileged to have amazing mentors and supervisors that I can say, you know, this feels uncomfortable. Some of this for me, and it is just for me, is about trying it out, and it is about getting it wrong sometimes, and kind of checking in with that and going, well, what was that about? Because it sounds very woolly, but that's how I feel like I've moved forward. I have done reading around it and I have tried to understand it, but the only training I've had is, I shouldn't say only because it was great training, was an advanced communication skills course many years ago, and it was phenomenal. It came through a head and neck cancer route, and I have to say that was powerful because we had to do role play with an actor and it was filmed. Terrifying. But it did kind of challenge me in a way that I don't think my colleagues would challenge me, or my peers or my family would challenge me. So if you can reach out for any of those kind of workshops, I really recommend it.
I think for that came from Macmillan, because I think I've done this as the same one, and it is an incredible experience. If you can experience, I think often if they're not filled up with the head and neck Macmillan population, they are available to just all healthcare professionals, and I completely mirror. It was a life-changing experience for reflecting on what you think is perhaps a good communication exchange, but actually how it felt for the receiver of that exchange. Yeah, great, thank you. Anything from the panel that that resonated with them? I'm just aware we've not got, it's one of those topics where I think specific questions, it's more of a discussion, isn't it, which on this platform is quite tricky. But whether there's anything within you guys that resonate. Helen?
Yeah, I really liked, you were talking about parking your clinical bias. And I wondered if you had any more top tips for how to go about parking that bias, or what it would look like.
Yeah, I think for me, it's checking in. Why am I making the decision I'm making? So I'm going to use an example. I hope she doesn't mind. A colleague and a friend rang me going, I've got this baby, but listen carefully. This mother is feeding this baby. So smooth brain, so, you know, motor and neurologically potentially quite poor. She's feeding him. I mean, she was literally screaming down the phone, hysterical at me, going, she's feeding. I'm also aware I'm so old that I still do the phone like this and not like this. Just putting it out there. You know, she's feeding him. She's feeding, and I just remember sitting there going, like, stop. Is there chest infections? Is there? And she went, no, but she's feeding. I said, why do you keep saying that? She said, well, he's got to listen carefully. And I went, he might be doing okay. And I said to her, just go and watch. Like, you don't have to make a decision there and then. And I think that's my biggest tip to myself is permission. And I'm saying it cautiously. I'm, you know, as I say, I've worked in community, it's rapid, but safe practice is checking in. And I think sometimes we too quickly go to, I need to make a decision here and now. You don't. And actually, it's not good clinical practice. You've picked a day and a moment when they may look like this, but what do they look like on that other day and moment? So for me, I think the tip is really, it's a bit about the parking is just a pause. So this information is important, and I think I'm going to try and understand what I'm looking at and what I think, but I'm also going to be open, I suppose that's a big word, to hearing the truth of the parents and seeing what I'm seeing rather than going, I'm definitely going to see X. Does that make sense? I'm not sure that's tips, but.
Yeah, no, that's good. That's good. Oh, Sue, yeah, go ahead.
Sorry, Helen, did you want to pick up a question that came in the panel?
No, I've just been quietly making a list of my own.
Okay. Oh, well, sorry, I'll be really quick. So just 2 comments from me, Louise. Thank you very, very much for that. I thought it was absolutely fascinating as an adult therapist who has had children on my ITU, our ITU, with trachees come in for neurosurgical procedures. So already existing tracheostomy children coming in for neurosurgical procedures. So the parents have come in as these kind of experts. And I just wanted to make a comment about the power dynamic that goes on in that instance where the team, who the team is, who has the most knowledge, has to be completely reconstituted. And actually that's a threat often to some of the nurses and some of the kind of medical hegemony that exists in terms of where the knowledge sits and who has that knowledge and who is the decision maker. And it's been quite a challenge to me to kind of get the neurosurgical teams, the neurosurgeons, who are very clever people, you know, to acknowledge that actually with the tracheostomy tube, I am not the person who knows the most, but it's the parents. So I just realized that made me think, yes, next time I have a child in, I must remember to be much more overt, much more planned in the way we have those discussions before the patient gets in, if we can do that. To talk about how we're going to manage this child with a trachea. And then my second point was just about your brilliant observation about the comprehensive skills that we all have as speech and language therapists to look at, to observe communication and interaction. And my passion is to skill therapists to work with patients, particularly on ITU, which is my background. But I think a child with a trachea is a very specialist area, which I could see would really freak some people out. And for you to say you've got something to offer, if you don't know anything about that trachea, you can go and you can observe the communication, you can make some, you can tell what's going on with communication, you make some advice, was music to my ears. And I really want that message to go out to the profession that, you know, you don't have to have 59 degrees to go into an ITU. You can go in and contribute to the care of this person. So I really loved your comment on that. Thank you. I'll shut up now.
No, I just thank you, Sue. And I suppose one of the reasons for trying to celebrate those broader skills is I heard from a tribunal of a child with a tracheostomy, and unfortunately they weren't successful at securing speech and language therapy funding because finding a speech therapist with tracheostomy experience was like finding hen's teeth. And for me, I don't ever want to hear that, because actually that child could have some benefit. I'm not ignoring specialist skills, and I really hope that's being heard. But I truly believe these children are not picked up in community or in other settings because the lack of, or the presumption of lack of skill. I'm not saying people should be flying around sticking valves on, please don't, I will cry. But I'm saying that we do have skill and opportunity here. And I think that link, you know, I really, I hope Vicky's agreeing with me here, the great knowledge and experience they're willing to share across tertiary units out. That's the whole point. We want these kids to be flourishing in community. So empowering clinicians to see what the bag of tools they do have is vital. So thank you, sir. And it's really nice to hear from an adult perspective. I love ICU, so I'm probably biased.
Yeah, I mean, that is what we would be saying, agreed with Sue's comment that actually that is exactly the same as what we would be saying to adult speech and language therapists about our adult population who are in the community as well. You know, please don't not accept a referral because there's a tracheostomy. Again, reach out. We can provide you with information about that bit and what you need to know. But again, there's that wealth of information and input that we can provide to enhance communication and swallowing with that patient, regardless of that. So yeah, that's fab. Anything else that cropped up? Oh, Vicky's got
yeah, can I just I just wanted to say thank you, Louise. It's such a beautifully crafted presentation. I definitely couldn't have done it, and I thought a lot of it was really applicable to children with tracheostomies, but also probably lots of children, young people, adults with a whole variety of conditions. And a lot of what you talked about, I hope I do some of, and some of it comes with experience, doesn't it, and opportunities to practice. But I just wondered, I know you talked earlier about working at UCL. Are you getting your talk across to different groups, different people, to sort of different settings?
Yeah, so UCL's a ABI lecture, so it's a very specific lecture. So I'm not working for UCL. I'm doing my I am doing my professional doctorate at the moment, which it is lending its way to compassionate care and what that looks like. And I obviously have a big interest in technology, but no, and I mean, it's a good point actually, because as SLTs to be, that's probably where we need to start. It's definitely how my experience was quite early in my career, just not quite what I felt like was just constantly failing, or just failing with families and not quite hitting the mark. And I suppose that's where my learnings come from and will continue to come from. I'm not going to get it right every time. But it's a good question. It's a good thought. It would be nice to impact early and start thinking about how we can support clinicians develop that confidence. And it's more than confidence. I want to be careful with the word confidence, because it's not about confidence, it's about connection.
Amazing. I think we will leave it there. There's some chat. Apologies. All of our panelists can see each of us on a gallery view, and I'm aware that you as listeners can't see that. So apologies if it didn't quite work out. It wasn't as easy listening, but I will try and sort that out for the next time. There's some comments in the chat box about kind of reaching out for contact details as paediatric therapists working in other settings, and I'm sure that the guys on the committee and Louise I will speak to them. I'm sure they're happy to share their details to reach out. So if there's anybody else or whatever, you can email the CEN committee, and we will make sure we link you in with the people who link in and who can help you. And that's always our role. So any question or query, please do contact the CEN, and we can reach out to members who may be able to help. Thank you so much for that. I'm not going to share my screen because I had problems before, but I just wanted to say that Helen, right back at the beginning of all of this, put in some feedback. As always, we're really keen for feedback on the sessions, not just our technical hitches, please, just about the content, any future content that you'd like to see, and that kind of thing. And also volunteers. Louise is kindly here with us today because she volunteered her time and her expertise to share with us. So we would be really keen to reach out to anybody else who has got anything, a presentation, a case study to share with us. That would be really great. Also, just to say before we go, and again, there is the link at the beginning of the chat, and we will circulate to members. Our next webinar, which we're really excited to announce, is on the 6th of May. At a slightly later time of 2:30, because joining us is Kirsten King, who's the Vice President of Education and Research at Paediatric in the States. The title of her presentation we're working with her on, but essentially it will be about the pressure changes in tracheostomy and one-way valves and how that looks. So full title to TBC, but obviously a really exciting opportunity for us all to do some learning on that day. So as I say, I will circulate it. So thanks ever so much for joining us. Thank you, Louise, again for your amazing talk. It was really, really fab. Thank you for sharing. And we will see you all hopefully on the 6th of May. But as I say, anything else, please be in touch and take care. See you all soon.